Thank you very much. So I'm very grateful for the opportunity to present this topic, and I want to thank Stefan and Professor Schweppe to ask me to do it. Here you have my conflict of interest. So they are related to master classes where I perform surgery to demonstrate the treatment of ovarian and deep endometriosis. And coming back to the topic, just by chance, it was my work last year where I prepared this topic for the guidelines of the French College of OBGYN. So the topic concerns the indications and complications related to the surgery of endometriosis as they were available in the literature up to 2018. And far from more, I had to propose recommendations and to grade them depending the strength of the studies. So let's start by surgery of minimal and mild endometriosis. And in this topic, we have randomized controlled trials, one performed by Christopher Sutton and Dover Parjessen Abbott. And both randomized trials demonstrated that removal of or ablation of small superficial endometriosis improved pain. However, both studies also revealed placebo effect related to the surgery, meaning that patients who had only diagnosis, laparoscopy, could feel better after the surgery. And when the cohort was followed up to 5 years, then they observed that excision and ablation are comparable in efficiency on pain. There are also two randomized trials assessing the efficiency of the surgery of mild endometriosis on fertility. I think that everybody in this room know the study of Marcoux and the death of Parazzini, two randomized controlled trials with opposite results, because Marcoux demonstrated that the surgery of minimal and mild endometriosis is efficient on infertile women, and it increased the rate of pregnancy, while the other randomized trial could not find a difference. However, when both randomized trials were pooled in a meta-analysis, the efficiency of the surgery in infertile patients was demonstrated, so we concluded that complete excision or ablation of endometriosis lesions is recommended to improve pain and fertility when such lesions are revealed during the laparoscopy in painful or infertile women. However, sometimes we can perform laparoscopy in a patient for another reason, and we can find small endometriosis lesions that are supposed not to be painful. So we have a study reported by a Norwegian team. So they recalled patients managed for tubal ligations, and they asked them if they are painful, and then they looked at the medical report during the surgery, and they compared women with superficial lesions, asymptomatic superficial lesions, and women free of lesions. And they could not demonstrate that superficial lesions, which were not treated during the laparoscopy, were followed by pain in women. However, they were women with tubal ligation, meaning that they were rather elderly women, meaning that women around 38 or 40 years, which were not painful before this age, or less likely to be painful later, even though small endometriosis is not treated. As regards the lesion prevention, there are several studies demonstrating that using the anti-adhesion products may decrease the adhesion score. However, we have no study demonstrating that this reduction of adhesion score has an impact on pain recurrence or pain reduction and fertility. As regards the ovarian endometriosis, so we have rich literature about the what has happened here? Yes, about the impact of endometriosis on ovarian function. So, as you know, endometriomas may impact ovarian function because there is a chronic inflammation, there is a progressive disease of primordial follicles, a dysregulation of the folliculogenesis, and this impact may be related to ovarian volume, meaning that larger cysts or more harmful than small cysts, and we can observe a decrease of ovarian reserve related to endometriomas. However, you have to keep in mind that when you perform the surgery to remove the cyst, to treat the cyst, we can decrease the ovarian reserve due to the surgery. Because there is no cleavage, histological cleavage plane between the cyst and the ovary, so when you perform a stripping, usually we remove a piece of ovary along with the cyst. And the loss of the ovary may have harmful effect on postoperative fertility, and I showed 8 years ago that this effect may be higher in large bilateral or recurrent endometriomas. So it is recommended to perform a preoperative assessment of ovarian function before the surgery. Now, endometriomas are very rare isolate lesions. So in the large majority of cases, and in my opinion always, endometriomas are associated with lesions on the peritoneum or even deep endometriosis lesions. So when you perform a surgery for endometrioma, you have to have a close look on to thoroughly explore the pelvis and the abdomen. We are not sure that the pain is related to endometrioma, maybe when endometrioma are too large, but small endometrioma is not demonstrated to be responsible for pain, meaning that associated lesions are more likely to be responsible for pain and should be treated at the same time. Recurrences. We have a good idea about the risk of recurrences after the surgery of endometriomas because we have several randomized trials where the surgery is performed and the patients are followed up with or without medical treatment. And in the arm without medical treatment, the rate of recurrences may be as high as 29% after 2 years of periods. This is the randomized study of Renato Serracchioli from Bologna. And the same randomized trial demonstrated that if you give a continuous pill, you may decrease this risk threefold. So we recommended that postoperative continuous contraceptive pill to be given in patients with no pregnancy intention. However, despite the potential harmful effect of surgery of endometriomas on ovarian function, when we assess the postoperative pregnancy rate, we may have a pregnancy rate as high as 75%, and with a high rate of spontaneous conception, meaning that the surgery is efficient on pregnancy intention. Now, as regards the ablative techniques, it has been demonstrated that performing ablation of endometriomas using the bipolar current is not a good idea. There are 2 randomized trials showing that when you perform the ablation using bipolar current, you have higher recurrences rate and lower pregnancy rate. This is not the same results using the CO2 laser. And we have a very nice randomized trial performed by Paco Carmona in Barcelona with a long follow-up, up to 5 years, demonstrating that the pregnancy rate is similar between cystectomy and ablation using laser. However, they observed a higher immediate recurrence rate, meaning that probably the ablation is not always feasible when compared to the cystectomy. However, the ablation using laser may be related to a lower AMH decrease after the surgery. As regards the plasma energy, this is the technique I started performing in 2009. So I'm very satisfied with this technique, and I have very good pregnancy results. And we're even in low AMH, patients with preoperative low AMH. However, as we have no randomized trial comparing the plasma energy with the cystectomy, we could not conclude that this technique would be recommended. And the same thing about the 3 steps management in very large endometriomas. There were 2 surgical steps, so drainage, followed by a medical step, amenorrhea for 3 months, then the surgery of endometrioma. So this, I routinely use it in cysts larger than 8 to 9 centimeters. However, we could not recommend it because we have no data, comparative data with a high level of evidence. Thus, our guidelines recommended the cystectomy as a referral technique, but the surgeon should keep in mind that as there is no histological cleavage plane, he cannot find an actual cleavage plane between the ovary and the surgical plane between the ovary and the cyst, and it is very likely that when he removes the cyst, his cyst also removes a piece of ovary. So he has to take care to the preoperative AMH, because if the preoperative AMH is low, it's very likely that it will be even lower after the surgery, and this fact may impact on the results of the postoperative IVF. And we also recommended that the cystectomy should be abandoned when the dissection is very difficult or there is too much blood. And also in large cysts, large and bilateral cysts, in women without pregnancy intention, young women without pregnancy intention, we also should consider the preoperative oocyte preservation. As a matter of fact, when we treat surgically ovarian endometrioma, we have to find the good balance between the willing to decrease the recurrences risk and to preserve the fertility. And it is very likely that when we are more aggressive, we will reduce the recurrences risk, but we will also decrease the fertility rate. That's why in my practice, I preserve the cystectomy to women with no pregnancy intention, and I rather perform ablative technique using plasma energy in patients with far pregnancy intention, but this is not a recommendation, it's just my own opinion. As regards the surgery of deep endometriosis, we focus the colorectal endometriosis because this is the more frequent form of severe deep endometriosis, and there is a myriad of case series with deep colorectal endometriosis. And all the series conclude that the surgery improves the pain, improves the quality of life, is followed by good rate of postoperative pregnancy. And also, it seems that the surgery increased the probability of spontaneous conception in infertile women. However, the same series focus on the risk of postoperative complications, which may be even severe. Also, the recurrences risk is rather low, inferior to 10%. I speak about the recurrences on the bowel. However, everybody knows, everybody agrees that the surgery of deep colorectal endometriosis requires surgical skills, experience, and involves multidisciplinary teams. We have data about the comparison between laparotomy and open surgery and laparoscopy, and the team of Tenon Hospital in Paris demonstrated through a randomized trial that the spontaneous pregnancy rate is better when the surgery of colorectal endometriosis was done laparoscopically. So we recommend to perform laparoscopic colorectal surgery each time it is feasible. So there is an improvement of pelvic pain, dyspareunia, digestive symptoms, quality of life at midterm. We said midterm because we have very few studies with long-term follow-up, meaning more than 3 or 5 years. So we concluded that the surgery of colorectal endometriosis can be proposed in symptomatic patients with colorectal endometriosis. Now, what kind of surgery? And you know that there are two kinds of surgeries, the conservative techniques and the radical technique. Conservative techniques may be shaving or disc excision, meaning that we conserve the rectum and we just excise the nodule with opening or not opening the bowel. And the radical technique is the classical segmental colorectal resection. The conservative techniques decrease, particularly the shaving, decrease the risk of postoperative complications. And in our opinion, using the study we performed in Rouen, it seems that it improves the score of gastrointestinal quality of life. However, the recurrences seem being higher after the shaving, because we observed 8% of recurrences 10 years after the surgery. But we also observed that whatever technique we use, we rarely could perform a microscopically complete resection. So even you perform a colorectal resection, it is likely that microscopical satellite implants may be left on the bowel. However, it is not sure at all that these microscopical implants could develop after the surgery. However, you have to keep in mind that when you perform a low colorectal resection, meaning that perform the colorectal resection on nodules involving the lower rectum or mid-rectum, there is a significant risk of low anterior rectal resection syndrome, and this syndrome dramatically impacts the quality of life, meaning that the patients may be much worse after the surgery than before the surgery. So take care on the management by radical surgery in low colorectal nodules. So this year we reported the unique randomized trial comparing the radical to the conservative surgery of colorectal endometriosis, Andor, and we did not observe in large colorectal endometriosis, we did not observe significant better functional outcomes related to the conservative surgery, even though we observed a higher risk of bowel stenosis after segmental resection requiring additional endoscopic or surgical procedure under general anesthesia. However, we observed that in patients managed for colorectal endometriosis 4 years after the surgery, the pregnancy rate was as high as 81%, and a majority of pregnancies were spontaneous. So this is a very good point of the surgery in infertile women. As regards the complication rate is very variable through different series, because the series are very different in terms of localization of the disease, of the severity of the disease. But when you perform this kind of surgery, you should prevent the patients that they may have postoperative dysuria in some cases, or rectovaginal fistula in 1 to 3% of cases, or leakage, or pelvic abscess. So preoperative information should involve the risk of these complications, even though this risk seemed low. As regards the prevention of these complications, I think I lost the... Yes. We could not conclude, after long discussion, we could not conclude that if stoma is recommended or not in patients with rectovaginal endometriosis, because even though the randomized trial in colorectal cancer demonstrating that in low colorectal resection the stoma should be performed, we could not agree in the group of experts that this data may be extrapolated to women with endometriosis. So we said just that the surgeon should inform the patient about the probability of the possibility to perform a stoma after the surgery of endometriosis, especially low colorectal endometriosis. And we disrecommend the use of anti-adhesion agents in patients with rectal sutures because it has been demonstrated that it could increase the risk of postoperative fistula. Now, as regards the surgery of urinary tract endometriosis, we had only retrospective studies, and we observed that in these retrospective studies the surgery is efficient on pain and also avoid the silent progressive atrophy of kidneys due to ureteral endometriosis stenosis. As regards the surgery of bladder endometriosis, we did not recommend to perform it through cystoscopy alone because there is incomplete resection of bladder endometriosis. And we observed that the laparoscopic cystectomy is efficient on pain and recurrences risk. We could not conclude whether or not the GG stent should be inserted, and it's very likely that insertion should be considered in low bladder endometriosis involving the supratrigonal or trigonal endometriosis, and we recommended to use resorbable sutures to close the bladder, and also to keep the bladder catheterization for 8 to 10 days. As regards the ureteral endometriosis, you know that 3 major techniques can be used. The first is the ureterolysis, meaning that we completely free the ureter and we remove the stenosis. The ureter is not actually involved, but only compressed. Then, when we have an intrinsic ureteral endometriosis, we can perform the resection and end-to-end anastomosis or reimplantation into the bladder. And it was our opinion, and my opinion too, that we have no accurate preoperative assessment able to indicate that the ureterolysis can be or not performed alone. So it is impossible for me to anticipate if a patient with stenosis or hydronephrosis may require only ureterolysis or we have to perform reimplantation. The GG stent, of course, should be inserted, and this data come from urologic studies, and it is recommended in France to involve multidisciplinary surgical teams in the management of ureteral endometriosis each time we perform a reimplantation into the bladder. As regards the extrapelvic endometriosis, umbilical, diaphragmatic, or thoracic, or abdominal wall endometriosis, the surgery is efficient and should be recommended in symptomatic patients. As regards the hysterectomy, it seems in the literature that if we perform a hysterectomy along with the surgery of deep endometriosis, we also treat the symptoms related to adenomyosis, and also we prevent a recurrence of posterior adenomyoma, because a majority of rectal endometriosis looks like posterior adenomyoma coming from the uterus and involving the rectum. So removing the uterus seems to decrease the risk, seems to improve the pain after the surgery. However, you should reserve the hysterectomy in patients who are sure not to wish last pregnancy, another pregnancy after the surgery. And the risk of recurrent surgery due to pain is reduced when you perform hysterectomy along with the excision of endometriosis lesions. And furthermore, it is very low when you also perform the oophorectomy, adnexectomy. So we recommend it to reduce the pain recurrences in women with no pregnancy intention. As regards the oophorectomy, which aim is to induce definitive amenorrhea and to stop the estrogen production in the ovaries, we have only retrospective data, and we cannot conclude if performing oophorectomy ultimately improve or not the quality of life of patients because they are definitively menopausal. However, as I show you in the previous slide, it seems that the risk of recurrence of pain is lower if the oophorectomy is associated with the hysterectomy. But recent studies published in obstetrics and gynecology show that the mortality, long-term mortality, increase when the bilateral oophorectomy is performed too early. So we have to prove the balance between the risk of recurrence and the risk of increased early mortality in older women. And honestly, we have to discuss with the patient this possibility of bilateral oophorectomy after 45 years, but maybe not earlier. And the last recommendation was that the hormonal therapy may be proposed in patients with complete surgery, but I completely agree with the previous presentation that you have to add progestin in order to decrease the risk of cancer in residual endometriosis lesions. So there are 3 slides of references, and I would like to invite you in Australia next year at the World Endometriosis Society Congress in Melbourne, and also to invite you in Bordeaux if you have to spend some days or some weeks in the operative room. Thank you.